I'm just going to introduce Wendy Smith. She's a doctor in NPH. She works at Legacy and she's in her addiction medicine fellowship at OHSU. So kind of a unicorn doing the OB and addiction medicine. So I'm really excited to have you here. Come on.
Well, that is super nice, and thank you so much. So just as Stacy said, I have been an OBGYN hospitalist at Legacy for the last 14 years, and I had the good fortune to working with some of you, and also to really get a taste and experience of pregnant people in our community with substance use disorders. And I think feeling as though I wasn't able to provide the real help I knew I could was a little bit of a frustration for me. And so I had really the great opportunity to take a step away from what I was doing and join the OHSU Addiction Medicine Fellowship. I am a fellow. My kids say, oh, you've gone back to school. My 90-year-old mother-in-law says, how's school? And actually it is kind of school because there's so much learning and it's really, really fun. And I haven't had that kind of time to really take a step and take a breath and learn something that is so important in a way, and then be able to hopefully bring it back to our community. So it's been great. It ends in mid-July, and it has been just a year full of fun and learning, and I am the oldest fellow they've ever had in their entire lives. They don't know what to do with me. All the patients are like looking at me, and I'm like, I know nothing. I'm a learner, So these are my objectives today. We are going to review substance use and pregnancy, both nationally and regionally, and talk a little bit about the medications that can support pregnant people who are recovering from substance use disorders. Disclosures are here. I will talk about pharmaceuticals that are not specifically approved for use in the pregnant population, and I'm sincere about this last one. I recognize that pregnant people do not always identify as women, and I will always strive to use inclusive language, but there are going to be times that I'm going to use gender terminology, whether by accident or because a study uses it, and so I apologize for that, and I really do understand and want all individuals to feel seen, heard, and respected about their choices. So I'm sure you've seen some of this, but in 2007, the US maternal mortality rate was 13 deaths per 100,000 live births. And since then, that death rate has just been rising and rising. There was a peak in 2021 of 32.9 deaths. And then in 2022, which is the latest data that we have, it dropped back down to 22.3, moderately similar to 2020. That was likely following the impact of COVID-19. We also see the significant disparity in maternal mortality rates based on race and ethnicity in the United States, and Black and Indigenous people have rates over 2 times higher than any other racial or ethnic groups in the United States. Also, people living in rural areas have a 50% higher risk of death during pregnancy, and many studies have shown that Medicaid insurance has been consistently associated with worse pregnancy outcomes, and Medicaid, it covers the bulk of pregnancies in the United States. And so all of the policies of Medicaid really impact the people that are getting care here. I'm sorry about that. Those are all my circles. Despite the advances in obstetric care in the United States, maternal mortality rates remain much higher than other high-income or even upper-middle-income countries. Even with similar ethnic or racial groups within those other countries, they have a lower mortality rate than the population of that group within the United States. And so these disparities really highlight the ongoing challenges in the United States and our healthcare system, especially likely due to the unequal access to quality care and persistent racial and ethnic inequalities. Another factor that has been identified as influencing the rate of maternal mortality in the United States is the escalation of behavioral health disorders, and that includes substance use. We are seeing this rise in substance use, particularly in opioids and alcohol, affect teens with a uterus much more than those without. SAMHSA is the Substance Abuse and Mental Health Services Administration, the national group that looks at substance use and creates policies around it in the United States. They conduct a national survey of drug use and health every year, and they found that more than 2 million girls use illicit drugs, and they use them that way in 2023 compared to just over 1.7 million boys. So we're seeing a much higher rate of use of substances in girls over boys. Studies have found that women who engage in preconception binge drinking, marijuana use, and opioid use have increased odds of experiencing an unplanned pregnancy. They have more difficulty making, they sound good, effective contraceptive choices, and they can really, their use really starts to compromise their ability to make decisions around contraceptive use when it matters. Many people use substances during pregnancy and outside of it. Pregnancy seems to be a protective factor for substance use, and it does affect the prevalence. In non-pregnant people of reproductive age, we see about 64% using substances, mostly illicit, but in pregnancy, that rate drops down to about 18.6. Generally, people that are unable to decrease their use of substances during pregnancy are more likely to have a substance use disorder, and those are the people that we're most likely to really create an impact in by identifying that. We saw the maternal mortality rate in the United States, and we saw its rise up and that peak in 2021. At the same time, we've also seen a steady rise in overdose deaths from substance use, especially opioids and stimulants. Maternal mortality that's associated with substance use is just one of the many, many reasons why it's so important to, again, identify and offer interventions at this time. Just to kind of go back to Oregon and what we're seeing in Oregon, the latest data that we have is from 2018 to 2020. There were 37 maternal deaths, and these were all reviewed by the MMRC, the Maternal Mortality and Review Committee, which is an amazing mandated committee for each state, which I have the incredible honor to be on currently. Of the 37 deaths that were reviewed, they found that 17 were pregnancy-related, and the most common reason for death was mental health conditions, behavioral health conditions, including substance use. Substance use disorders, just like any health disorders, relapse and remit. Just as asthma and hypertension, people kind of lose their mojo around them, and you need to kind of continue to encourage them. Same with substance use disorders. And so we need to treat it like a chronic disease. There will be recurrence rates, and there will be periods of stability. The graphic on the right evaluated the mean number of attempts with confidence intervals within those lines that are necessary for a person to undergo attempts at recovery from substance use, and the mean, depending on the substance use, is somewhere between 2 and 5 times. So the key, again, is continuing to engage patients every time they have a touch point in their system to screen them, to offer interventions, and to offer counseling around harm reduction if that's where a patient is at. Especially because pregnancy represents this really unique time where people may be more ready to interrupt their use, ACOG, the American Congress of OBGYN, recommends that all pregnant people are screened for substance use. There are at least 3 validated tools to screen for substance use. I'm hoping that each one of you are using these. They each have a negative predictive value, meaning that if it comes out negative, the likelihood of it being a true negative is between 86 and 91%. Universal screening via this verbal screening tool is not to be confused with doing a biologic test, which is what a blood or urine sample is all about. Really, only after a positive verbal screen should we additionally evaluate whether the need is there to do a urine test. And there are very particular situations, which we'll talk about later, as far as testing for urine. And it's really important to remember, a urine test is not a parenting test, and a positive urine drug test does not indicate a substance use disorder. So what does indicate a substance use disorder? I think we throw these words around, and I think sometimes it's hard to know what it actually is, so I'm going to tell you that. A substance use disorder has a very particular definition. In 2013, the American Psychiatric Association came out with the DSM-5, and that the DSM-5 replaced the categories of substance abuse and substance dependence into a single category called substance use disorder, and then within substance use disorder, there are 3 classifications: mild, moderate, or severe. So the DSM-5 describes substance use disorder as a problematic pattern of use of an intoxicating substance leading to clinically significant impairment or distress occurring within a 12-month period. The symptoms that are associated with this mental health condition fall into the 3 major groupings of impaired control, social impairment, and risky use, and physical criteria, and that includes tolerance and withdrawal. So these are the criteria that are required for a substance use disorder. Depending on how many you check off, then leads to whether they have a mild, moderate, or severe disorder. And that's how we should all be classifying substance use disorder, and how we should be understanding it, the impact of distress on a life and the impact of use on their life. So the DSM-5 also recognizes 10 classes of substance use disorders. This is a partial list of some of the more common substances that your patients may be using. Interestingly, most of these, but not all of these, can be classified by the DSM-5 as a substance use disorder. There are some that can't, but alcohol use, nicotine use, cannabis use, opioid use, stimulant use, sedative use, hallucinogens, and inhalants are probably the most common. Within that, many of these do have disorders. Some of them don't. I'm going to point to kratom, which is down on the side over there. Kratom is essentially a drug that you can buy in gas stations and stores that are completely unregulated. They have opioid, they bind to the opioid receptors, they have stimulant effects at different concentrations, and it's a really risky substance that your patients are using and may not tell you about if you don't ask them about it. There are other ones as well, but this is kind of one of the more common ones, and I see a lot of nods, yeah. So the stakes, and I think I'm going to be preaching to the choir here, but the stakes for how we talk about pregnancy and substance use are very high. Stigmatizing language contributes to really harmful narratives, and this is what keeps people from getting the treatment and support that they really need for themselves and their family. So we all have the responsibility to do better and use an approach that respects people's journeys and elevates the solutions that we can provide. So I'm going to talk specifically now about opioid use. Opioids are endogenous and exogenous. They are naturally occurring or synthetic, and they're all substances that bind to specific opioid receptors. More than 50% of all the admissions to substance use programs, in pregnancy in particular, are opioid related. Fentanyl, and I really want to emphasize it, and I think this is what you guys all know, but fentanyl is this very potent synthetic full agonist opioid. It is fairly inexpensive. It has a very rapid onset. It's very short acting, and it's highly lipophilic, meaning it loves to get into the cells and the fat in our body and sit there. And this causes some of the problems when we try to manage it. So much more so than some other opioids that were used in the past, like heroin or illicit prescription pills. Fentanyl just sticks around in the body, and I think it's really important to remember that. What's happening right now in our community is mostly what's called fetty powder. So it kind of has gone through this phase that the blue pills that we often hear about are kind of not around anymore. These were pretty inexpensive, and a lot of people were crushing them and smoking them, but they're harder to find now, and so people have turned to powder. And one of the things about all of these pills, and powder in particular, is contaminants within them. We just don't know what else is in them, and we often see different things within it. People can inject fentanyl, they can smoke fentanyl, they can inhale fentanyl. There are many ways that they use it, and those are all things we want to know about because their action is a little bit different. So opioid-related overdoses are a leading cause of death for pregnant and postpartum people in the United States, and the number of deaths have increased significantly over the recent years. The latest data that we have around this is from 2018 to 2021, and the mortality rate for opioid-related overdose among pregnant and postpartum women has increased by more than 80%. The most rapid rate of overdose is actually in the early postpartum period, and studies have shown that risks of death postpartum are actually much greater than during pregnancy, and I have a lot of theories about that, but I think it's really important to remember that anytime you can engage a person is not too late because they are really at risk postpartum as well. So how do these opiates work? They bind and activate to mu, kappa, and delta opioid receptors. Their psychoactive properties, including kind of the euphoria, the tranquility, and some of the analgesia that you think about, underlie a lot of the non-medical use that we see, and it comes from activating the opioid receptors within the central and peripheral nervous system. The riskiest effects of opioids, I think as many of you know, are respiratory depression, and this is caused by binding opioid receptors within the cerebral cortex and the thalamus. Also, there are some receptors within the respiratory system and the mechanical receptors that actually cause a hypoventilation symptom when you take in opioids, and when you stimulate those, you don't breathe as much, and so you get hypercapnia and hypoxia, and that leads to the risk as well. And then I think you all are aware of other adverse effects: constipation, decreased libido, and actually decreased reproductive ability are related to opioid use as well. It affects the hormonal system in both men and women, or females and males, and can really impact reproductive and menstrual issues. They also can blunt the immune response, and you can get poorer wound healing from activation of receptors in other parts of the body. So important to know that opioids cross the placenta and the blood-brain barrier of a fetus. There are no certain fetal anomalies that are related to maternal opioid use, but there's this new novel syndrome that's been identified in neonates whose mothers use fentanyl during their pregnancy. There's a very cool study that came out just last year. It talked about this new syndrome. Primarily, they see physical findings right now for the babies, including microcephaly, decreased growth, some facial features with ptosis or drooping eyelids, short anteverted nasal tip, micrognathia, small jaw, cleft palate, syndactyly in their toes, a picture down there, genital anomalies, and a dysgenesis of the corpus callosum. It's currently thought that these changes may result as an effect of fentanyl's inhibition of cholesterol synthesis during pregnancy. And so we're probably going to hear a little bit more about this syndrome over time. It was something that was new to me and actually has been identified out in Medford, close by, and they're looking at it. So additionally, untreated opioid use disorder is associated with preterm birth, fetal growth restriction, placental abruption, fetal death, passage of meconium, stays in the NICU, and then, of course, neonatal opioid withdrawal syndrome, or NOWS. Again, I just want to emphasize, and I can skip through this, but pregnancy is a really unique time of opportunity for all of us. Every pregnant person has insurance, right? So you've got this opportunity where they have they have this coverage, and it's been shown to be a time where people are very motivated to make changes in their health behaviors. There was a study that was done that looked at a very large group of women who found out they were pregnant, and 56% of them said that they wanted to make a change in their health behavior during their pregnancy. The feeling is that it's this identity shift going from a non-parent to a parent that opens up someone's mind to learning more and making change. And so we have to look upon pregnancy as a time with the opportunity for teachable moments. All right, so one of the things that we can do as clinicians that take care of people with substance use, in addition to approaching them with empathy, with understanding, and with a focus on promoting this positive change, we really use this time to talk about the things that we can do. These are our interventions and resources. So medications for opioid use disorder are called MOUD. They have multiple names. You can look in their literature and you can see it as MAT, as OAT. I'm going to refer to it as MOUD, Medications for Opioid Use Disorder, and these are the evidence-based first-line approach to treating opioid use disorder in all people with OUD, or opioid use disorder. They reduce the chance of an opioid overdose that's related to death by 50%. They reduce a person's cravings and withdrawal symptoms, and they increase the likelihood that they will continue to not use drugs. They also have been shown to reduce pregnancy risks and complications, including the preterm birth, low birth weight, and NOWs that we see with opioid use disorder. They also reduce the risk of infectious diseases, and for our patients and for patients with opioid use disorder, that's really important. So they've seen decreased rates of HIV, syphilis, and other STIs. Interestingly and importantly, MOUD is associated with a larger mortality reduction than almost any other medication that we use for any medical condition. And just like any other medicine that we use, we need to be open to patients needing to change what they're using, right? The first medication that we choose for someone or that they choose isn't always the right one. Be open to that and work with your patients. Each of these medications is safe and effective. So this was a 2023 study by Zoo. It compared non-pregnant people of reproductive age to pregnant individuals, and what they found is that during pregnancy, people of reproductive age pregnant people were 1.57 times more likely to start buprenorphine than non-pregnant people, and they were 2 times more likely to initiate methadone. And really importantly, and what's shown on these slides, is they're also more likely to continue these medications over time, which is even outside of the pregnancy. So again, pregnancy is this time where we have great opportunity and we need to take advantage of it. All right, so what do we have available for us? There are 3 FDA-approved types of MOUD. Methadone, I'll talk about first. It's a synthetic opioid. It's a full agonist. It binds to and activates the mu opioid receptors as well as others in the brain. It reduces cravings. It reduces withdrawal symptoms as well. Methadone, as many of you know, is very highly regulated. It can only be dispensed for opioid use disorder in specialized treatment programs called OTPs. So that word and that understanding is really important. Initially, people always need to go to an OTP to get their methadone. Over time, with stability, using methadone, people get take-home doses. So it's a process, and we've been so lucky as a part of this fellowship to get to work in an OTP, and it's been really enlightening. Buprenorphine is a different substance and I think is always the one that people have a little bit more trouble with. Buprenorphine is a partial agonist at the mu opioid receptor. What that means is that it doesn't reach the potency level or that height that methadone or other full agonists have. But this also leads to the safety of buprenorphine because you don't get that really strong action at the opioid receptor. You also don't get that same triggering of the problems with respiration and ventilation. So it is a safer medication when it's binding to the opioid receptor. The other thing that it doesn't do, because it doesn't reach that height, is it doesn't create that same level of euphoria or sort of the pleasure that's related to that increased potency. But another feature of buprenorphine that's really important to remember, and we'll talk about it a little bit in the future, is that it's got super high affinity. It like gets sucked onto the receptor really, really tightly, and it can kick off almost every other full agonist opioid. So if you've got a full agonist opioid bound onto that mu receptor, if you get some buprenorphine on board, it's gonna kick it off and bind on instead of it. So it's got a really super high affinity. This is called the ceiling effect when you get that like limitation of effect from the buprenorphine. I think some people, when they take methadone, do feel, they feel good. I think a lot of people describe feeling kind of good on it, but people on buprenorphine tend to be a little bit more likely to just say, I feel normal. They don't get that same little bit of euphoria or high that sometimes people with methadone get. I don't want to characterize anybody. Everybody has their own experience with it, but buprenorphine tend to just want to get to that feeling of normalcy. And then there's naltrexone. That's over on the end there. Naltrexone blocks the euphoric and sedative effects of opioids. It acts as an antagonist on the mu opioid receptor. Just like buprenorphine, it's got really high affinity for that receptor, but it's blocking it. It's an antagonist. So it's important to remember that opioids can't act on that receptor when naltrexone is on board. And that's one of the features that keeps us from using it in pregnancy. Again, I'll talk a little bit more about that. So every pregnant person with an opioid use disorder should be offered methadone or buprenorphine at every interaction when you've identified a substance use disorder, if they're open to it. MOUD, as we saw, is associated with improved maternal and perinatal outcomes. And although MOUD, both methadone and buprenorphine, is associated with neonatal withdrawal syndrome, and so it's very important to discuss it with all your patients, generally the NOWS, the neonatal opioid withdrawal syndrome that we see is less intense, less severe, and requires less medication than that we see with other opioids and certainly with fentanyl. This is a graph that shows just that. So this is showing what babies have severe NOWS related to fentanyl use at the time of delivery and no fentanyl use at the time of delivery. So the red group are babies that are born to moms with a diagnosis of opioid use disorder who were positive for fentanyl at the time of delivery. The blue group is a group of babies that were born to moms who have opioid use disorder but had a negative fentanyl test at time of delivery, and many of those patients were on MOUD. What you see is a whole shift towards the left in that red group, so a much higher rate of severe NOWS in those babies who have fentanyl on board at delivery. So fentanyl has really kind of changed the game for all the people that work with people with substance use during pregnancy, and I think it's just really important to remember that everything we're talking about today in using MOUD, the comparison, for the most part, is using fentanyl. So, very importantly, buprenorphine and methadone are safe during pregnancy and lactation. And this does include most formulations of buprenorphine, and I'll get into that. It reduces pregnancy complications. You see higher birth weights. There's decreased HIV risk, decreased fetal mortality risk, and overall a lower rate and severity of NOWS. And so I do want to bring up naltrexone. I talked about naltrexone, that antagonist agonist to the mu opioid receptor. Well, how come I'm not talking about it now? Well, naltrexone is an evidence-based treatment option for people with opioid use disorder, and naltrexone is safe in pregnancy. That's really important to understand because it's a great medication too for people who are pregnant with alcohol use disorder. But in general, it's recommended to not initiate naltrexone during pregnancy for MOUD. There have been many small studies comparing its use with methadone and buprenorphine, and there have been seen even better effects on outcomes of NOWs and when babies can leave the hospital. But there is some concern for return to use risk for moms. And at this point, the feeling is that there's not enough data to support initiating naltrexone in pregnancy. If someone comes to you on naltrexone, it is supported to keep using it if that's what a mom wants, given the data that we know about it. And really, again, shared decision-making is huge here. Suarez in 2022 did a retrospective study comparing methadone and buprenorphine. They looked at 22,000 babies born to mothers on buprenorphine, and they compared it to 9,500 babies whose moms were on methadone at the time of their delivery. And this is what they found as far as outcomes. The rates of growth restriction, of NOWs, and that 52% should be over on the buprenorphine side. And preterm is a little bit higher in the methadone group. However, what they showed, sorry, this is a little messed up, they showed a lower rate of return to use on methadone. They also showed increased stick-to-itness in the postpartum period. With buprenorphine, 9% growth restriction, 52% NOWs, and 14% preterm. So you may look at this and say, I know what's best, right? But you're wrong, because the best medicine is the one that the patient wants and will take, right? So we give them the data and they get to choose. A little bit more about methadone. Methadone is rapidly absorbed. It reaches its peak concentration in the blood between 2 and 4 hours after ingestion. Generally, methadone effects are sustained for 24 hours over time. It's a long-acting medication. However, in different individuals with different pharmacokinetics, and then also in pregnancy, the half-life can actually vary from 8 to 59 hours. So it's really important to watch what's happening with your patient. We always want to get an EKG on people that are going to start methadone and then who are on higher doses of methadone, because very, very rarely it can be associated with a pretty scary condition called Torsades de Pointes, which is associated with a longer, what's called a QT interval, kind of an electrical impulse. In general, incredibly rare. Probably we're making too much of it, but nonetheless, we have to consider it. And then this is a map of all the OTPs in Oregon. So remember I said that everybody has to start off going to an OTP. Well, there are only 17 Oregon State OTPs in the state, right? And 8 of them are in the Portland metro region. So, I mean, what do we do for all the people that live in the deserts, right? Methadone is not an option for them realistically unless somehow they want to move, and I have seen people move. So I think that's really important in the counseling when you're talking to a patient. If you start a patient on methadone and they can't continue it, that's not the right medication for them. During pregnancy, as I alluded to, there are normal physiologic changes, as you know, right? One of them is an increased fat cell volume, and remember we said that fentanyl is very lipophilic, and so is methadone. And then you also get a very significant rise in the activity of the P450 enzymes. You're gonna have to think back to your days. I know you all know this because it takes some time, but you do all know this. So the CYP enzymes, it's CYP3A4 and CYP2B6 are responsible for metabolizing methadone. In pregnancy, the enzyme activity increases like crazy. And so most people who are on methadone outside of pregnancy and then get pregnant need an increase in their methadone dose by about 50% is what's shown in the literature. And it's not because they're... they're doing anything. Their body is literally, metabolizing it out, and so you need to be very aware of that. Additionally, you may see a lot of patients who are pregnant on split dosing, right? It's a long-acting medicine in general, but because it's chewed up so quickly in pregnancy, the one thing that can happen that can be really problematic for people is that it goes to a very low. It's called the trough level, right? And so when we look at the trough levels in pregnancy, they get very low. And it's those trough levels that lead to withdrawal and lead to cravings. And so when you split the dose and give it twice a day instead of once a day, you see a higher trough level. You prevent withdrawal, you prevent those cravings. And so we generally don't give it more than twice a day, though I think there are some people who may need that. But when we think about how the action of pregnancy is, it makes a lot of sense. The evidence around it is not great, I will tell you that, but clinically it makes a lot of sense and people seem to feel better. One thing, I think there's a lot of lore about what people need after pregnancy. We always sort of say, let's go back down to their pregnancy dose. Well, what studies have found is that, one, the physiologic changes that are associated with pregnancy can last at least 3 months, probably longer. But if you look at people who were on methadone during their pregnancy and talk to them about their cravings and symptoms and titrate your methadone based on that, people who are postpartum almost forever need higher doses. They wind up about 20% higher outside of pregnancy than they went to inside of pregnancy. There's some theories around that. Nobody really knows why. Some people think there's been a permanent change in their receptors. I don't know, but it holds true over and over again. We looked at some of the pregnant people in the OTP where I work. Held true. It's amazing. You don't want to make these changes like blindly. You want to look and talk and see how patients are feeling, right? We don't want patients getting increased sedation or having the problems because they're on too high of a dose. So titrate per sedation and cravings. I think, sorry. Yeah, and so this is a rapid titration for methadone that we use in the hospital setting. Outside of the hospital setting, you cannot go up this quickly. You'll never see someone go up this high so quickly. And I think if you talk to Dr. Reagan there, maybe this isn't even as high as he goes up. But this is sort of a standard rapid titration of methadone. We're watching for sedation. We're watching symptoms. We've got a pulse ox on. We can do this safely, and we can get people feeling pretty comfortable pretty quickly on methadone. All right, buprenorphine. I'm just going to do a time check for myself. So buprenorphine, very high affinity for the mu-opioid receptors. It'll kick off other opioids. Because, again, it's only a partial agonist at the receptor, one of the greatest risks of starting buprenorphine is that you can get something called precipitated withdrawal. And I'll talk about that in a second. This is just a graphic of comparing the little yellow dots, which are buprenorphine, and their partial agonist effect with that big green full agonist. You can see they each bind to the receptor. The buprenorphine leaves little spots in between, but is covering a good part. The full agonist can't bind over that because it is so sticky on that receptor. So what's precipitated withdrawal? I don't know if you've heard about this or not, but it's the thing that really kind of frightens a lot of clinicians and patients about starting buprenorphine. So this picture represents what happens during precipitated withdrawal from buprenorphine. So the soccer ball is sitting on the mu receptor. It's a full agonist. A little tiny buprenorphine comes in as that single soccer player. Because the affinity of the buprenorphine is so great, that soccer player is going to bind onto the receptor and kick the full agonist off and sit there. But because there's only one soccer player instead of, are there 11? I don't know, something like that. Like 10 others, you don't get the full effect. You don't get, my kid played soccer. I don't know. I watched it in a lot of rain. I'm sure I was on my phone most of the time. I don't know. But you don't get that same potency effect. And so you've got a little soccer player on there, they've kicked off the full agonist, and now that person's going to start to go into withdrawal because they've pushed off those really, stimulating full agonists. So you need to get some more soccer players in there to bind to that receptor pretty quickly. Now, precipitated withdrawal isn't usually treated just by throwing more buprenorphine on it. It kind of depends. People often need some full agonists. They sometimes need some benzodiazepines. They even need ketamine on board. But it's a pretty bad thing that can happen, and it happens quick. So it happens generally within about 15 to 30 minutes at most, and so you know it's happening. If someone just sort of says, yeah, I don't feel so great after that first hour, the answer to that is throw more soccer players on that receptor. Get that receptor filled up quickly with buprenorphine. But that's what precipitated withdrawal is all about. So if you hear those words, that's what you'll never not think of this soccer player again. Buprenorphine comes in many different formulations: sublingual tablets, films, and 2 long-acting injectables. Studies have shown that there's no difference in using either of these formulations. Very importantly, and I think a lot of you do know this, is you can use the combination formula of Suboxone, naloxone, which was developed archaically to prevent people from injecting, which never actually worked really. And anyway, there was always this concern that it wasn't safe in pregnancy. Totally safe in pregnancy, no problem. And then there's a mono product that just has buprenorphine called Subutex. All safe, all effective. You do need to take them sublingually under your tongue, let them sit there for 5 to 10 minutes, let them completely dissolve. And you don't want to swallow buprenorphine tablets because the bioavailability of a swallow tablet is less than 10%. Whereas when you take it sublingual, it's between 30 and 50%. I do want to talk very quickly about Sublocade or Brixadi. These are the extended injectable buprenorphines you're going to hear more about soon, I suspect. They are currently not approved for use in pregnancy. That has never stopped anyone from using something during pregnancy because what is approved for use? There are several small case series. There's really no long-term outcome data, but one of the biggest studies that's been done came out in 2024, and they compared groups of women, patients retrospectively who were pregnant and their outcomes. 8 of them were on the injectable, 15 on the buprenorphine alone, and 37 on the combo product, Suboxone. What they found is about 38% of people during this time were still using illicit drugs. 93% of all the babies were born full term. But really importantly, 25% of the people, and again, only 8, their babies didn't need, only 25% of their babies needed pharmacotherapy to treat NOWs, as compared to 52% and 67% in the sublingual buprenorphine. So this is something you're going to hear more about. Can you use it now? Well, you need to do some shared decision making, right? I mean, do we use it now? Yes. So yeah, I mean, it's been a bit of a game changer, honestly. I think you guys mostly know what COWS is. I'm going to kind of just quickly, these are the withdrawal symptoms that people get when they are withdrawing from opioids. We have some really great medications that can help with some of those opioid withdrawal symptoms. There are things that sometimes we don't use a lot of on labor and delivery or with pregnant people, but I think some of them we do. I think sometimes we give them scheduled if someone's really withdrawing to get them comfortable while we're getting them onto some MOUD. Sometimes, we also do want to give them when people need them. We don't want to create a new use disorder with any of these medications. None of them really fall under the use disorder category, but we have seen difficulties with tizanidine, even trazodone, and a little bit less with clonidine, but they all can be misused just like any drug can. So care with those should be taken, and yet they should also be used liberally to make people feel comfortable. We always want to be aware if someone's going on methadone that some of these will also prolong their QT. We talked about that Torsades de Pointe. That can be a real problem. So really quickly, how do we make people comfortable and not go into precipitated withdrawal when we initiate buprenorphine? There have been some really great new ways of doing this that have allowed it to happen more comfortably for people. One of the things we always want to be aware of, again, is the lipophilicity of fentanyl. It takes a while for fentanyl to leave the system. It sits in those fat cells. It sits in the cells. If you start to give buprenorphine too early, you'll get precipitated withdrawal, right? So we need to be careful. We need to give enough time. This is called a rapid low-dose buprenorphine initiation. This has been, again, a game changer in being able to try to avoid precipitated withdrawal when we start buprenorphine. We are sneaking in little teeny amounts of buprenorphine. We're using a full agonist as we're doing it. We finally get to an amount, about that 9 milligrams, where that covers about 85% of the mu receptors. And if you can get there, we can then load the rest of that up as needed pretty quickly. So once we get to that 9 milligram dose on day 4, we stop using generally generally a longer acting but full agonist agent. You can use a short acting if you need it. You can use all those adjunct meds I just talked about. But usually when you get here at that 9 milligrams, you can load them up quickly to the rest that fills up more than that 85%. Most people who use fentanyl need doses around, I will say 16. In pregnancy, that's probably too low, so 24 to 32 milligrams of buprenorphine. But you can load that up on day 4 and be done and get people feeling pretty good by day 5. Okay, I'm going to take a pause for a time check. I have 15 minutes. I have a case that I was going to go through, but I want to make sure we have time for questions.
Who wants to do a case?
Okay, all right. So this case primarily is something that I see all the time coming into the emergency room often in pregnancy, and then I get drawn in as an OBGYN hospitalist. So this is a 28-year-old. She comes into the emergency room. She has 2 days of lower extremity swelling and redness. The emergency room doctor is super thorough and likes to take care of patients who are pregnant in the emergency room, said no one ever. But she doesn't remember her period. I don't know, maybe like 3 months ago. She is sexually active. She doesn't usually use contraception. She's in the emergency room alone. You ask her about her housing. She's unhoused at this time. Her partner left, and she hasn't seen him for a day, and they're trying to find the dog. So in the ED, her pregnancy test is positive. And so this, again, very astute ED doctor screens her using the 5 Ps for substance use, and she screens positive. So then that very astute doctor asks her about her substance use, right? This is the time that we're going to find out, do they have a substance use disorder? So this is a patient who smokes fentanyl. She's been smoking for about 4 years, pretty much every day. She used heroin prior to that. Occasional methamphetamine use for about 10 years. She was kicked out of her home due to use. She's had sexual assault when she was using. She's overdosed times 2. She used fentanyl 12 hours ago. She used methamphetamine 20 hours ago. She sort of knew something was up, and she said, yeah, I'm trying to decrease my use. And I think I'd really like to try to decrease or interrupt my use of fentanyl. So you score her, and she comes up with a score of 8 on the DSM-5 criteria, and that signifies severe opioid use disorder. And you score her for methamphetamine, because for each substance that someone's using, you score them each time. And she has what's called a moderate methamphetamine use disorder. So then that very astute doctor goes down to examine her, and she looks at the vitals, and she's like, well, the heart rate's a little bit high. Yeah, her blood pressure, okay, that's pretty good. Her respiratory rate's a little bit high. I want you to recall the physiologic changes of pregnancy that lead to some of these things, right? A normal heart rate in pregnancy is up around 100. It is not uncommon for someone to run 110, and that's because their blood volume through that second trimester, third trimester is increased by 50%. Their hearts are working hard. Their respiratory function is working hard. They have a smaller tidal volume. Their progesterone is huge, and that triggers them to breathe more quickly. So I call these vitals normal. Looks at the cellulitis. There's nothing red flaggy about it. They are at risk for MRSA because they use injection drugs. They look at the pregnancy. Well, the uterus is above the fundus, so something's up, right? And then they assess their substance use disorder. They have 5-millimeter pupils. That's dilated. Dilated withdraw. That's how I have to remember it, dilated withdraw. So that's associated with some withdrawal symptoms, mild nausea, anxiety, a little bit of restlessness, a little moist, yawned a little bit. All of those are opioid withdrawal symptoms. So they give them astutely, as we're waiting for an ultrasound, ondansetron, clonidine, hydroxyzine, some gabapentin, and some Tylenol. They know not to use NSAIDs. They get an ultrasound. She's 28 and 6. They start her on some Bactrim orally for her, they call it a mild cellulitis, and then, of course, they call you, me, us, OB, I don't know, whoever works in labor and delivery, says, we're getting rid of her, we're sending her up to you, she's 29 weeks. So we bring her up, we do an NST, it's reactive, and then she's just starting to feel a little anxious again. So I want a raise of hands. Who would admit this patient to the hospital? Awesome. Who would not admit this patient to the hospital? I'm looking for recommendations. What would you recommend? Okay, awesome. Okay, me too. Okay, so these are the top 10 reasons why you should consider admitting this patient, okay? What I found out is that many people who are less than my age don't know who David Letterman is. I'm so sorry. So it can optimize treatment of their cellulitis. It can reduce the risk of progression to sepsis. It can allow for any co-occurring conditions, right? This is her first presentation to care. It can allow for care coordination, referral, and engagement with peer navigators. There's an increased acceptance and adherence to MOUD when it's done in the hospital. It's associated with improved attendance to prenatal care. It can reduce getting her on MOUD reduces her risk of preterm delivery. That's huge. Less severe nows will result. Less maternal mortality will result. And this is covered, right? So OHP in Oregon allows us to admit any pregnant patient with a code of O09.XX to, which is a supervision of a high-risk pregnancy, to initiate MOUD in the hospital. But the number one reason it's the right thing to do, right? So you recommend admission for this patient. You're feeling really good about this decision, but then she says, I just can't. I can't stay. I'll come back. I got to find my partner. I got to come back. And so they are going to leave, right? And this is your touch point. There are so many options, right? I mean, you can do harm reduction. You can, I don't know, would anybody offer MOUD at this time as an outpatient? Okay, yeah. So there are options for offering MOUD initiation as an outpatient, not necessarily methadone, though with the 3-day rule of methadone, I'm hoping you've heard about this, the 72-hour rule. In theory, we could start it. That's really difficult. So I'm going to primarily, she wants buprenorphine. Let's go with buprenorphine. So I'm going to steer you to something called the California Bridge. They have great treatment protocols. I have the website on my slides. They have come up with a specific quick start in pregnancy protocol. Now, I want to warn you about this patient. patient. She used fentanyl. Now it's been about 15 hours. Is that enough time for this patient to not go into precipitated withdrawal, right? I mean, everyone's shaking their head. I agree. I mean, they don't say no. Nobody says no, but I feel really uncomfortable because one of the requirements is that you have to show this patient's in withdrawal, but you also have to feel pretty good about the idea that you're not going to throw into precipitated withdrawal. So you gotta have some guts to do this. If you're gonna do it, you need to do it in the hospital and be prepared to treat precipitated withdrawal, right? So give that first dose in the hospital. If you get by, you send her home, with these meds. You send her home with adjunctive medicines that we talked about. Give her naloxone in her hand. Make an appointment for her to follow up. I know you want to refer into Project Nurture. I know you've all heard about that, and Nurture Oregon, absolutely. But she needs something definitive. Harbor Clinic at OHSU, a virtual low-barrier buprenorphine clinic. Any of you can give this patient that number. They can get a same-day appointment to have ongoing buprenorphine prescribing. I still advocate for giving as much buprenorphine as you need to get through this induction. This is the second option. This is a little bit safer, but this means that you're feeling good about her going into withdrawal at home. If the alternative is ongoing fentanyl use, I say go for it. Everybody has so much fear around allowing a pregnant person to go in withdrawal. I scoured the literature to see what the effects are. I can't find anything. I really can't. There's old lore, there's data that suggests, but honestly, now more and more, if you can get that patient on adjuncts and not using for 72 hours, they can go through a self-start at home. We call this a traditional start. Generally, you start with 8 to 12 milligrams and then get them up at once pretty quickly through the day on their buprenorphine, These are what you would discharge them with very clear instructions on how to do it. And then finally, you can do that very elegant, rapid or not so rapid microdose induction. You can take what we were going to do in the hospital and you can do it as an outpatient. We do that at Harbor for people who are living on the street. Now, it's hard in pregnancy. You would like someone to be around them. It's hard to send somebody home. I'm not advocating for this necessarily, but if you can figure out a way that she can be safe, one of my scenarios on this is I have had patients who suddenly are pregnant. They call their mom and they're like, I'm pregnant. And they say, come home for a little while. I mean, I know that's maybe a little idealistic, but it can happen. And if somehow we can arrange for that, you can start MOUD for this patient. And so this is an outpatient titration. We call it a crossover titration. The patient continues to use their own full agonist opioid. And in this case, it's fentanyl. So they're using fentanyl and they're transitioning off of fentanyl. I know that feels hard, but so is using fentanyl, right? If someone is going to leave your hospital anywhere using fentanyl, give them the phone number to never use alone, right? This person is alone. Do not let them use alone. This is a group that will call. She can call. She tells them where she is. She tells them, I'm going to use. If she does not answer when they ask her to answer, they will send out EMS for her. So it's a great number to know. And finally, this is what you would send her home with. It's a little more complicated. I would recommend using 2 milligram films and helping her cut them into pieces so that they can use them over time. And then you send them home with their tablets or films as they wanted, 8 milligrams. It takes some time to get this through, but it's worth it. And I just want to leave you with this. The greatest thing that I ever heard a pregnant person say to me after we completed their buprenorphine initiation, I never even thought it was an option for me to be a mom. This patient said to me, I just assumed I couldn't come here without giving up my baby. And this is what your patient is thinking, right? So that is the first barrier we need to get over. So thank you so much for listening. I really appreciate it. Ooh, I have 1 minute. Does anyone have a question? And you're going to get all these slides.
Sorry. So if you have someone who's willing to stay in the hospital or go in the hospital, like when you were down in Medford with us, we've definitely had some scares with doing the Suboxone in the hospital and a couple of precipitated withdrawal ugly situations. So we pretty much stick with methadone. If you have a choice and the patient doesn't have a preference, what would you choose?
I choose Bupe. I mean, I really do, because these rapid low doses are really elegant. They really are. I think we have kept people incredibly comfortable on methadone and adjuncts. And I think ultimately, if you can get them on a injectable, before they go, it's like a dream. It's a dream. Makes me want to cry. I think it's always worth a try because it's so easy to convert from buprenorphine to methadone. It's not as easy to convert from methadone to buprenorphine, and that's a lesson I've learned. Thank you so much for all your attention. I really appreciate it.